How does ARNI fare in patients with HFpEF? Now, HFpEF, basically, we find that many of the is a conglomeration of many pathophysiological states which adversely affects the heart's function. So whether it is metabolic stress, aging, unfavorable cardiac remodeling with stiffening of the entire vasculature, whether it's ventricular or vascular stiffening, and this is associated with obesity, sedentary lifestyle, and this affects the entire body. You know, the cardiac effect of the metabolic stress is because of the myocardial lipotoxicity and diastolic dysfunction and increase in the afterload and preload. And it is associated with pulmonary pathologies where there is restriction in the compliance of the lungs, reduced vital capacity, impaired ventilation, obstructive sleep apnea, and pulmonary hypertension. So similarly, we find that CKD, chronic kidney disease, visceral adiposity, and increase in fat infiltration in our body, whether it is in the mediastinum, in the abdomen, central obesity, or all this leads to HFpEF. And the previous trials, whether it is charm preserve or TopCat and iPreserve, they showed a negative outcome. There was no benefit by using ACE inhibition and other vasodilators. So it seems that the clinical outcomes in HFpEF and HFrEF, once you put them shoulder to shoulder, we find that despite the preserved ejection fraction, symptomatic heart failure, preserved ejection fraction has as bad an outcome as that of reduced ejection fraction. Now, there were some trends which were noted, whether it is the NT-proBNP, the levels are lower once you treat HFpEF with ARNI. Similarly, the atrial size. The atrial size does, the increase in the atrial size, there is some remodeling, and this increase is much less once you put them on ARNI. They have more symptom relief. So there are some positive evidence of using ARNI in HFpEF. So we have to remember one thing when it came to doing important trials like the PARAGON heart failure trial. People who had class 2 to 4 heart failure with structural heart disease, elevation in natriuretic peptides, once they were subjected to or exposed to ARNI, they had significant improvement in their functional class, the time to occurrence of worsening of renal failure, time to all-cause mortality. So we find that there was a significant trend, and particularly hospitalisation and cardiovascular death. And this was in favor of the use of ARNI. Now, another important population is heart failure with mildly reduced ejection fraction. That is the group between ejection fraction of 40 to 57%. So the evidence which is showing us, which is that these actually behave like people with HFpEF, and they are also benefiting by the use of ARNI. So, heart failure with mildly reduced ejection fraction should be treated on same lines as heart failure with reduced ejection fraction, which is less than 35%. Now, here we are. The 2022 AHA guideline shows that the new FDA indication has opened up the use of sacubitril and valsartan combination, both in patients with reduced, mildly reduced, and now also in individuals with preserved ejection fraction.